Yes.
Thank you for the opportunity. I'm Dr. Navaneeth, medical officer from Arvind Hospital, Coimbatore. Surgically relevant associations of coloboma are small eyes, microcornea, shallow anterior chamber, small pupil, inferiorly deficient iris and zonules. Associated retinochoroidal coloboma, which decides main visual prognosis. This is a case of hard black cataract with microcornea and coloboma. ECC incision is given, which is of 8 millimeters length. Better is a valvular incision instead of a stab incision. This followed by a side port, mainly sclerocorneal, as if only corneal, it may obscure your view of during surgery. Here, people got dilated with sufficiently with intracameral midriatic, capsule stained with capsule stained and keratometry made. We can notice with the cystitome, we can notice a grossly bag, making the rex difficult. So capsular forceps used to make the rexis as big as possible. Nuclear dialing attempted bimanually with dialer.
Dr. Satanshu, please mute yourself.
Okay. So as it was difficult, relaxing cuts given over the iris as a superior iridectomy, and this followed by rexis relaxing cuts given with venous, and delivery reattempted, one pole dialed out followed by a vectis delivery, which got stuck at the tunnel. Now the tunnel relaxing cuts given and delivery reattempted. Nucleus delivery became successful with superior iridectomy, rexis relaxing cuts, and tunnel relaxing cuts. This followed by gentle visible cortex wash. Now the challenge comes as we have to implant 13 millimeters lengthy IOL with 40 diopters power in 4 millimeters cornea. So haptics were trimmed so that optic size becomes 6 millimeters, and we are able to implant in the bag. This followed by visco wash and ECCE wound suturing. Here the trick was, first I took all limbal to sclera bites all at a time and tied all knots at once, so that I can assess the tightness of the knots in more synchronized way. This is another case where the challenge was small pupil. This can be dealt with iris hooks, which were needed mainly in the superior quadrant. Extra side port made above the tunnel to put the third iris hook, so that I can view the superior part enough to visualize the rexis. After doing enough large rexis, iris hooks were removed to facilitate the remaining steps in the surgery. Nucleus dialed into anterior chamber and delivered with vectis. Here jonules were intact, so IOL kept inside the bag. This is another case where the challenge was inferiorly weak jonules. After sufficiently large rexes, mild hydrodissection is done, and weak jonules are supported with CTR. And the rest of the surgery is continued in a similar way. This is another case where the jonules were deficient in the inferior part. So after completing the rexis with capsular forceps, CTR placed in the deficient area. CTR got slipped from the bag because of the extended rexis. So at the end of the surgery, CTR explanted out. And 3-piece IOL implanted in the bag, and its haptic fixed to iris with the help of a Prolene suture passed below the haptic through and through the iris, which corrects both colobomatous iris defect and fixates the haptic of the IOL with one knot. This is the same 4th-row pupilloplasty which fixates both IOL and the iris defect. In summary, ECC is the choice of incision in microcornea and small eyes. Iris hooks and superior iridectomy can counteract the small pupil. Jonular weakness can be supported by a CTR. In gross jonular deficiency, iris fixated IOL or a scleral fixated IOL may be needed. In case of RC coloboma, which involve disc and macula, better to go for a basic IOL packages. Thank you.
Thank you. Thank you, Dr. Navaneeth. That was truly a wonderful presentation, and lot of examples and take-home points came. Thank you very much. I would take the question with anybody in the expert panel, Dr. Ravindra, and also Dr. Deepak Meghur. Anybody could answer. We all know that there is a disproportion in small eyes about the anterior chamber being shallow, very shallow in these microcornea eyes, and also the nucleus could be very large too. So what is the approach to prolapse the nucleus in these cases? What tip would you like to give? Even Dr. Navaneeth, you could answer. Anybody?
Same thing, ma'am. Larger incision with a, and sometimes
ECC. You said ECC. You wouldn't do a SICS, right?
Yeah, ECC is the choice of incision in my case.
Yeah, Dr. Ravindra, Dr. Deepak Meghur, anybody, Dr. Boramani, anything different you have to comment on this particular situation?
No, about the wonderful videos. I think they're all very heroic surgeries. I think I should really compliment now Dr. Navaneeth.
Yeah.
One thing is he cut the haptics and put the lens inside the capsular bag in one microcornea. And how did he manage? Was it a PMMA? It looked like a PMMA lens, if I'm right, isn't it?
Yes, sir. It's a PMMA.
How did you manage to put a 6mm PMMA through probably a 3 or 4mm axis? What was that? And what about the rough edges of the cut portion? Does it damage the capsular bag? And how did the patient do?
Iritis or inflammation?
Post-operatively, how did the patient do?
We saw the 6 months post-op also, sir. It was looking very stable also, sir. Like,
which is a situation when we would not implant an IOL in a microcornea. It's a hypothetical question, but I'm sure such a moment might come when there's a certain corneal diameter, I believe, no? When smaller than that, we would not implant an IOL, right?
yes.
Many times it depends upon the axial length of the eye. If axial length sometimes is normal and you have only the microcornea, and I will expect the lens to be of a larger size. I think it's nice to have a different collection of lenses with you. And many times you will be able to, like a 9mm, 8mm cornea has got 23mm axial length. probably the lens size is normal, and you can find out by UBM preoperatively as to the size of it, and then plan the exact size. And any lens can be custom designed. And we're fortunately in India, and we can make lenses. I've made lenses of 10 millimeter overall length. I've made lenses of 8 millimeter overall length. And they're very happy to make and give it to you, though they're a little expensive and takes time. Custom designed lenses are a way to go in these eyes.
He showed iris hooks being used in small pupil. Now, since this is a lens coloboma and an iris coloboma, the rexus, it's going to be a little decentered. Does it not make sense that even in routine cases, wherein we could end up with an asymmetric rexus, that we use iris hooks in all cases? Anybody think similar? Or would you reserve using iris hooks only for small?
There are two things that I would like to say. One
Yeah.
is that in these eyes, usually the cataract is very hard and cornea is little smaller. So one has to make a very large incision in these cases. And as Dr. Navaneeth has shown, extracapsular is the right way to go. And pupil dilates in most of the cases. Some of the cases, I will see so they may not dilate, then you can use iris hooks. And the nucleus is so big that I would like to do an envelope technique, or even can opener is very good in these cases, because the prolapse of the nucleus becomes very easy if you are doing in a very hard cataract. It might otherwise come with a bag in the anterior chamber. So for the beginners, it's always advisable to do a small can opener technique from the very beginning. Nucleus is hard, you might touch the endothelium and you will have a very bad cornea the next day.